Welcome to Next to Madison, a podcast to help you live your best life.
Welcome back to another fun episode of Next to Madison. On this very important and special episode, we are talking about something that every single person really needs but kind of struggles with, and that is the topic of sleep. You hear so many people that struggle with sleep apnea or sleep insomnia or running to over-the-counter meds. I've been very guilty of it myself, just to ensure that we get a good night's sleep because we're running 24/7 and we're constantly being stimulated. So I am sitting down with the founder of the Cleveland Research Sleep Center, and he is now going all over the world, particularly right now in Pakistan, studying sleep and helping people with these disorders. So we are focusing on sleep apnea and chronic insomnia for this episode particularly, but he's got some great cures that you never would have thought of. So you're not going to want to miss this episode. We'll be right back after this brief message on Next to Madison with our guest.
It's your host, Madison Malloy, and I have exciting news. My new product is now available on Amazon called Color Your Way to Abundance, a 21-day manifestation guide for wealth, health, and love. This unique coloring journal will help you manifest by coloring in the affirmations while you continue to repeat them. This will help activate these affirmations so they become a reality. Grab your copy today and relax, color, and start manifesting.
All right, we are back with our amazing guest on this very, very important topic, the topic of sleep. And with me, I have the CEO and the medical director of the Cleveland Sleep Program and Research, Dr. Mansoor Ahmed. Welcome to Next to Madison. How are you?
Thank you. Glad to be here.
Yes, I'm so glad to have you here because so many people suffer with some sort of sleep disorder. And I can tell you my own experience was around 2012, I started depending on over-the-counter sleep medications like a ZQL or a melatonin. And it's been really, really difficult to kind of get off of it. And so it's kind of been something that, and I try to stay to the natural, but it's kind of been something that I've been a bit dependent on. And a lot of people who have sleep apnea and things of that sort. So I want to get into this. How did you get into the field of sleep?
It's a long story, but make it short, that I was finishing my ICU training in Winnipeg. And we noticed breathing irregularities. The people stop breathing during sleep, particularly patients with congestive heart failure. And I've been breathing okay in the daytime, but when they sleep, they have a long rhythmic pauses. Every 1 minute, they will breathe fast, breathe slow, and then stop breathing. And that led me to think about that what is the link between the heart failure and the sleep apnea, we call it. And that essentially was, I think, the beginning of my the research interest. And then from that, I spent time in the sleep program. I think we studied many patients with sleep apnea. And sleep apnea is only one of the 80 sleep disorders. There are many more than 80 disorders. And chronic insomnia happened to be one of the most common sleep problem. So when you enter into the sleep area, it just opens up the whole horizon, what the sleep is all about. And then it was challenging insomnia in particular. It's very complex. It's really one of the most challenging, basically, although everybody present with the same symptom, difficulty falling asleep, staying asleep, waking up tired. Everybody almost has the same symptom. But how they get there, it's so many factors and so many stories. So it's a complex. And so one has to really, I think, have some idea, particularly the chronic insomnia, the short-term insomnia, you get over with that one. Every now and then you are stressed out, you get some bout of insomnia, difficulty falling asleep, anxiety, stuff like that, it goes away. But many are not fortunate enough. They continue to develop what we call the chronic insomnia. And I hope that we will be spending a lot of time in talking about chronic insomnia.
Oh my gosh. Okay. So what do you think? Because so many people suffer with sleep disorders. What causes it?
Well, I think that there are a type of the sleep disorders. Sleep apnea. The two, I think, if we can just basically focus for the sake of the time, the most common, which essentially has got a lot of attention over the last 25, 30 years or 35 years, is obstructive sleep apnea, snoring. People stop breathing. I think it becomes like almost like it was, even in 2000, nobody knew it. And then after that, when it just basically publicity and the research and how it affects the heart, how basically many people fall asleep and accident and all that. So sleep apnea, overweight, loud snoring, and stop breathing. And so that's essentially the one disorder. The other, I think the most common, the other two, is the chronic insomnia. I think at some point or the other, many of us will have some insomnia, but some of us are not so lucky to get out of insomnia. Such as you have anxiety, some stress, you may have a little bit sleep problem, but then there are some people will end up in having chronic insomnia. So very large patient population, even without any particular comorbid condition, they continue to suffer from chronic insomnia. That means that their insomnia lasts for months, for years, and it goes on and on. So that's, I think, the two problems. If we just basically deal with that one, I think we have to start to address the bigger issues of sleep. I think that I don't want to get very lengthy, but the most common, I think, the public health issue right now, the sleep-wise, is the inadequate sleep, insufficient sleep. We are living in 24/7 culture. We are on the WhatsApp, we are on the social media. We basically are almost like have the cell phone right to our chest to see if there's a message coming in. As a result of that, many of us, I think, through the globe, most likely don't get adequate sleep. So inadequate sleep with the resultant daytime consequences, including falling asleep while driving, work accident and all that. I think that is one of the biggest, I think, public health challenge from the sleep perspective. And then there are, as you know very well, the teenage sleep issues. I mean, they are habitually what we call them the night owls. They can stay up till 2 o'clock, 3 o'clock, and then they will have a difficulty in waking up. So after 3 or 4 hours of sleep, they have to go to school. As a result of that, they only have for 4 hours of sleep, and they need like at least 8 hours, 9 hours, 10 hours. Younger age, you need more sleep, but they are only getting 6 hours, 5 hours of sleep just because they develop the circadian rhythm problem, but also socially they are busy till 2 o'clock, texting each other and talking to each other, and then they fall asleep and they have to get up at 6 or 7 o'clock in the morning. If they don't have to go to school, they can still till the noon. So that is very, very, very common and very neglected problem, the teenage issues, particularly what we call them the night owls. So that is just to give you the gist of sleep disorders and, bad sleep habits, inadequate sleep. That comes entirely in the spectrum of the issues related to disturbed sleep.
So what do you think causes these two sleep disorders that we're focusing on for this episode?
I think that the sleep apnea, that's basically said, will be very brief. You may have come across, I think, a classical individual who are overweight, who have underlying hypertension, maybe heart disease. So overweight is one of the very, I think, common, but not everybody that who's overweight gets sleep apnea, but overweight, I think obesity is a very common risk factor for sleep apnea. Then there are, I think that the morphological characters, such as a very prominent tongue, a very narrow back of the throat, oropharynx is very narrow, and they don't have adequate space to breathe in while they are awake. They are sitting, but when they fall asleep, then they don't have enough space and the tongue falls back and then they stop breathing. So it's a complex, but very simple. Most common is the overweight. I think, and then they lie down and then they basically when they take the breathing in, they can't basically breathe in. They stop breathing for 10 seconds, 15 seconds, 20 seconds. They get low oxygen, they get higher carbon dioxide, and then suddenly they will sort of wake up and then they go back to sleep. So they neither can sleep properly. The moment they sleep, they stop breathing. So this cycle goes on and on and on.
So there's the machine that came out that a lot of people, even though they suffer from this, don't want to wear because it looks ridiculous. The sleep apnea machine, the CPAP, or something it's called,
Yes, yes,
where it
yes.
looks like you look like a monster.
Yeah, no, yeah, that's from the just for the sake of a little bit of what we call, it's always good to go to the history and the literature, the Pickwickian syndrome. I think Charles Dickens has the Pickwickian character, which basically was the initial literary description of somebody called Pickwickian character that who have a classical overweight, always basically sleepy, I think heavy cheek, heavy face and all that. So this is a literary story of Pickwickian and all that. This is the first, basically, the literary sort of a recognition of the sleep apnea way back in Charles Dickens, I think, novel. Now, coming back to now to call the CPAP. Now, CPAP is essentially, before the CPAP, what was the treatment for sleep apnea? Very important to know a little bit of a history of that, how the diagnosis was established. Now, what was the treatment of sleep apnea? Surgery. I think what was the surgery? Either you do the tracheostomy, like little hole over here, so you bypass the upper airway and you start breathing. I think very brutal procedure. Then came the, I think they go to the back of the throat, they take the tonsils out, they take the palate out, so the surgery was the only treatment. But the problem with the surgery was to make the throat bigger, that a lot of patients, 50% of patients may not improve. It's very hard to say who will improve and who will not improve. So that was the only stuff available, tracheostomy and the upper airway surgery. Then came, I think, in the 80s or something, that the CPAP, basically, which is called the continuous positive airway pressure, small machine, which can deliver the compressed pressure through the mask and to keep your throat open. It's very effective, but it's not, if you put the CPAP, people get improvement in sleep apnea. But as you rightly said, it's not easy to have every night to put the mask on, to struggle with the mask on. People use it, their spouse don't like it, patient feel heavy. Then
I was going to say, like, how does somebody, I mean, it must really have an impact on your sex life. I mean, nobody's going to roll over and be like, oh, let me have sex with this monster.
Definitely, it's not very sexy looking, the big mask like that. You have to do a lot of juggling to basically do whatever you want to. Yes, absolutely. That's one. But even the patient, basically, the mask issues, the leakage, and then something on the face. I think that is one of the major challenge. Although it is effective, but in the long term, the people basically have a hard time in putting it on for at least 7 hours a night, which we recommend. Hours. I mean, all night, every night, I think, so that's a major problem with the CPAP. I think effective, but people do not like to use it regularly. So compliance is a major problem. And then there's a lot more things we can talk about if you like to what exactly we have.
It seems that there's so much development in this area because it is such a common problem that, my dad struggles with sleep apnea and he didn't want to wear the mask, but my mom said, there's like minor procedures that can be done. So what are some other things that have come about to help patients with sleep apnea?
Well, you have the right examples and you are asking the right question, but we are not talking about the one of the most common sleep apnea, not chronic insomnia. Chronic insomnia is another big story and very.
We'll get into that one afterwards. Yeah.
All right. So yes. So the question is that what are the other options for sleep apnea besides this one, right?
Mm-hmm.
Well, I think in early 2000, even slightly before that, they came back with the dental appliances, the mouth guard, which essentially is sort of a device, the orthodontic, which you wear it at the nighttime. And essentially, its physiological principle is that it can bring the mandible slightly forward. So you put this sort of orthodontic devices in the upper and the lower jaw, and then you can manipulate and you can bring the mandible like 4 millimeter, 5 millimeter forward. By bringing this mandible a little bit forward like this, you're creating the bigger space at the back of the throat. And tongue become more stable, so tongue is not falling back. That's the principle called the MAD. It's called the MAD, Mandibular Advancement Devices. It's like an orthodontic. Dentists make it. ENT people can also look into that one. So that essentially has become the second, I think, treatment, which is it was not non-existent almost. We did the first time the oral appliances way back in 2000 with a gentleman who was the case question. He has his own lab and all that, and we start putting the dental appliances. The interesting story is that at that time, insurance company don't pay. There was a Medicare patient who came and he couldn't tolerate the CPAP, a Navy veteran. So we gave him a oral appliances. He got better. Now he
Oh,
said, well, how do we pay you? I said, well, my Medicare don't pay. I said, well, just have it pro bono. You are among the first few patients and all that. So he invited us on his board and treated us with a steak dinner, and we were eating.
oh,
So there's so many. I think so. Anyway, I think so. It is basically dental master's history, and we basically have I think treated thousands of patients with that one. I think another remember remarkable story. There's a veteran came, and he was going back on the duty in Afghanistan. How do you take the CPAP? When you are on the duty and the electricity and this and this and that.
yeah.
And severe sleep apnea, 55, 60 times an hour, stop breathing and all that. He came, and we did also the oral appliances. Fantastic improvement. And he took this little device, no CPAP, no machine, no mask. And he basically, I think, went on to complete his call of duty to Afghanistan. So I think it's just an amazing, I think, I think that the evolution of the sleep apnea happened over here. But dental appliances, they do also have a problem. We cannot predict that who will improve and who will not improve. But I think a lot of now, I think, ways to determine whether a person can improve with oral appliances. But that's the second option. And the third, the most latest was moved very fast forward, is called the Inspire. This is like a name of a company, which essentially is a pacemaker. So what it does that there's a pacemaker there. One electrode of the pacemaker go to the diaphragm, other electrode for the sensor, other electrode go to the tongue muscles called the genioglossus, to the tongue. So it stimulates the tongue when you're breathing in. So by stimulating the tongue right at that moment, when you are breathing in, the tongue becomes a little bit more stiff like this. Like this little bit stiffening of the tongue. So now you're breathing in and the tongue is stiff, it won't fall back. And then you will have no sleep apnea. It's called the Inspired therapy. So this is a pacemaker which you can manipulate. And so that is the latest treatment, the electronic stimulation of the genioglossus muscle and sensing the diaphragm, synchronizing them, and then you can have prevention of the obstructive sleep apnea. Not everybody, but people have a remarkable number of patients can benefit from that.
So what's that procedure like? Do they have to cut you open? Is it really invasive?
No. Well, it's basically they go to the ENT surgeon, they look at the throat, they look at that person is candidate, he cannot use the CPAP, severe sleep apnea. Then they do the pre-op evaluation and they stimulate, before they actually put the actual pacemaker, and they stimulate and to see what happens, and not everybody improves. So if they pass that test, the pre-surgical evaluation, then it's a little pacemaker, which basically is a small electrode. It's not like a completely opening it up and all that. It's a small pacemaker, which basically is the one of the wire is basically go to the tongue muscle, and other wire basically internally can hook up to the diaphragm. It is as simple as that. It's not a major procedure at all.
So it's non-invasive. They kind of put it through
it's
the throat.
invasive. I think that there's, so to speak. I think yes, that anything is a little bit invasive, but it's not a major surgery. This is a major surgery. The tonsil, then the UPP, but that's not the major surgery. So that is the other treatment. And the most recent one, just to close the loop, so we are up to date. And there's a recent, I think, the first ever trial on the weight reduction medication, as you know, all these Ozempic and all these compounds are basically also similar compounds. A lot of pharmaceutical companies, Eli Lilly basically came back with a new compound. They're similar. They did a trial on the people with sleep apnea, with the overweight, and by the weight reduction, they improved their sleep apnea. So that is the first medication ever approved for treating the sleep apnea because it reduces the weight. With the weight reduction, sleep apnea get better. Now, these patients who have a sleep apnea, they can qualify for this medication. So that is the latest buzz on the word.
So the medication is the GLP-1s that everybody's on.
Yes.
Okay.
Yes.
So that is
interesting. Yes, absolutely. GLP-1. And that is, I think, there's a lot of other pharmaceutical company. I think obesity, as you know, that is almost epidemic proportion, and there's a lot of pharmaceutical company are interested. And so medication which improve the weight by proxy also will improve the sleep apnea, because weight is one of the risk factors, not all of them. And many patients basically can improve the sleep apnea to the extent 50%, 60%, depending upon, I think everybody's different. But that is one FDA approved, official approved medication, which basically can give the relief or the sleep apnea. I mean, not 100%. There's no such thing in anything that you will sleep apnea for 50 per hour to completely zero, but definitely, I think 50%, 60%, 70% improvement, and along with improvement in symptoms, I will buy it. Like now you have some relief, your weight reduction.
Yeah.
That is the latest buzz on the market about this GLP compounds, the effect on the weight and thereby improving.
Yeah. No,
sleep.
absolutely. I think when like the rise in GLP-1s came out, some people looked negatively upon it because, you heard all the Hollywood celebrities that were either on it, not admitting it, or people that would lose so much weight and then their skin would be saying, and now they had different things they had to deal with. But not enough of the positive is necessarily come out, like reducing of if you're pre-diabetic or hearts or
Yeah.
strokes or all the things that like being overweight, just given, especially in America, our diets are so bad with the portions that there was all this benefit. So I think like maybe I don't feel like there's a positive enough campaign around GLP-1s. I think it's kind of looked at, I don't know, that's just been my impression. What do you think?
Well, I think that first of all, the epidemic of obesity is almost universal. I think I am right now in Pakistan, because there's nothing there. It's like a completely deserted field. This is where I come from, and I'm doing some program over there to educate, teach. So obesity is equally, I think, that the pervasive in those countries. Diabetes and heart disease and obesity is becoming like a universal almost thing. And there are different reasons for different causes. I think over here, I think you are absolutely right. Our dietary, the lack of exercise, probably the stress, the whole combination of the fact that we are having I think, epidemic of obesity. I think, but this is I think that probably the only medication, I think, over the years, there were many, many attempts over the period of time, the Jenny Craig program, this program, that program.
God.
And they came and they went away and all that. Then the keto diet came, Atkins diet came. But then again, this compound basically have a little bit very unique, as I'm not expert in this area, but I think it worked through the entirely different mechanisms. I think initially came for the diabetes, and then by weight reduction, I think was
That's
also
amazing.
The side effect, and then there are a whole bunch of other unintended positive consequences of the GLP, inflammatory response and all that. So I think they are looking at the different indication of this compound in different diseases. So this become like a new, all the elixir of life, that the GLP. And obviously one has to be cautious. Long-term studies are still, need to be looked very carefully. Longitudinal study, we get very hyped up, and then after 5 years, then you start to getting some more problems. So I think we have to be cautious. I think not that everybody who don't need it. There are side effects. Every medication has side effects, and there's no shortcut to the healthy lifestyle. Exercise, proper diet. That's difficult, but everything which is good is difficult as well. So people have to focus on that one before they resort to, let me take the pill and continue to, I think that nothing else, not the right approach and all that. We are treating the disease, but we are not preventing the entire epidemic of obesity. I think that emphasis basically, unfortunately, has gone out of the window. It takes a lot of time to consult diet and say, let me have a pill and let me just basically zip through this one.
Yeah, and I think our society is so programmed because we're so go that we don't, most people are lazy. They don't want to put in the work. So they're like, all right, let me take a shot, let me take a pill. Let me, I've had times where I've been so busy and I'm like, I can't get to the gym this week, and I'll go to a wellness center and pop a GLP-1 because I know that I have something coming up and I don't really want to eat for the next 2 weeks. But the side effect for a lot of people is that, and some doses have done this to me, I've just taken it mildly, is it makes you very nauseous.
Yes, side effects are there. I think that's why I think that my personal basically approach always have been, I think, know the patient, look at their stress, look at their life, have some time a little bit rather than simply writing the prescription in 15 minutes and then you go on your own. I think that's not the right way that we should be entering into that sort of a quick band-aid solution, I call it over there, more of a lifestyle. Know you a little bit over here. Look at your life in the bigger perspective. What is important for us? Your personal life, your social life, your psychological life. I think all these things are very important. by just taking the tablet without changing anything at all. Yeah, in certain cases we have to do that because they're diabetes, they're having other major complications and all that. Now they should not stop there. I think it should not basically now that have the pill, have this injection, take it over there, and you're done. I think that's, will have a consequences down the line. And the medication itself, we really don't know yet what is the long term after 5 years. As you said, that even the immediate side effect, the nausea, and then other, I think, side effects will all these medications, do not a single medication will be said that totally, it's not a placebo. It's a medication. It worked to a very unique mechanism. I got it. It is effective. We got it. But again, I think down the line, I think after 5 years, something like that, then you retrospective analysis. So yes, it has to be used with caution. Person has to basically change the lifestyle. Then it is probably one of the best, I think, as far as pharmaceutical intervention came with these CRP.
Yeah, well, it's supposed to be like an assistant, not like a dependent, right? So the one thing I noticed when I took it like mildly, just to, come at me, it's fine, is when it does wear off, you are so hungry. You just want to eat everything. And so it's really retraining yourself. And when it really wears off, you get those hunger pains that just hurt. And it's like, you got to fight through those.
I mean, we've tried so many things, cutting the stomach, gastroplasty.
I only had 5 pounds, but still, I was like, I wouldn't come off.
After the gastric bypass surgery, now the stomach is half gone. And then after a while, you're again starting to basically eat more, stomach become big, and then you basically lose the efficacy of the gastroplasty. So it turned out to be that the short-term band-aid solutions, I think, may not be the best answer for the long-term, I think, behavioral issues, diet issues and all that. I think it's not the right approach. Even if the GLP is working most effective, I will definitely emphasize on the stress, diet management, and the person to have the control of your life rather than depending upon the pill. You should be your environment to look at other things which are very, very, very important.
Okay. All right. Let's move into chronic insomnia because that's another big one. What are the main causes of chronic insomnia besides like stress?
So you can look at the chronic insomnia as a disease in itself, a disease in itself. You may not have to have any particular disease. So people can recognize depression, PTSD, and after that, many of those individuals have also comorbid insomnia. So there are other like medical conditions. I gave you the example of the psychiatric conditions. Invariably, most of the psychiatric disorders are basically associated, or comorbid insomnia is present in all those diseases. But individuals, we call them the primary insomnia, where there is no apparent cause. And they are, take an example that we all get stressed. We all get basically, I think things happen to us, but not all of us get the chronic insomnia. So I think to understand the chronic insomnia, so one, then there is just no apparent cause called the primary insomnia. You just constitutionally, physiologically, psychologically are very sensitive person. Any little thing, basically, you're hyper. You are basically, you're reacting, you're responding very differently. Your psychological way, your mind is set up. And then there is, I think if you examine these patients at physiological level, we call them hyperarousal. They're always, the brain is basically faster, or they are overreactive brain and all that. It never rests as much as, because sleep and wakefulness are two mechanisms which are competing with each other. An individual who have what we call the primary insomnia, they are in a state of this hyperarousability, that their EEG is faster. Even when they sleep, the sleep is lighter. And every now and then throughout the life, they struggle. Any little thing, they end up in having long bouts of insomnia, last for a while. And then over the period of time, they turn into, I think period of time with chronic insomnia, they just become part of the life over there. Then there are certain type of primary insomnia in which if you examine them actually in the lab, they're sleeping fine according to the EEG, 8 hours, but they just don't feel that they have slept. It's called the sleep state misperception. And those are essentially that we don't know. I think that is the whole thing with insomnia. All the patients present with the same symptom, but how they get there. So one is the primary, for which your hyperarousal state. You are very active. You are basically very sensitive. Anything basically which come to your way is a lot of ripple effect on your psychology, your well-being, and you renumerate. You basically go on and on, a hard time to relax. Have a baby, a pregnancy. Now the whole is over, but the whole the change of your environment and all that,
Yeah.
basically you have a different personality, different physiological way of handling that one. And those individuals, basically, we call them the primary insomnia. Then there's a very large, I think, group of chronic insomnia, which all of us understand very well. There's not cause and effect, but again, the chronic insomnia, which called the comorbid insomnia, is very, very common in underlying depression. I think underlying PTSD. There is no PTSD or depression or anxiety where you, at some point or the other, you will not have insomnia as a part of the whole syndrome. In fact, the definition of the depression and the bipolar disease, for example, is the disturbance in the sleep, the chronic disturbance in the sleep, they basically are part of the disease. And sometimes I think that even so there's a bi-directional relationship between the psychiatric disorder and sleep. A disturbed sleep predisposed to get more anxiety, and it increases the risk of developing depression. And presence of depression is associated with the chronic insomnia. And the third is that persistence of sleep disturbances as insomnia and patient with depression have a prognostic value. I mean, there is a nice study which was done many, many years ago. Young, I think, students, female students, they have a chronic insomnia, no apparent cause, and they followed them longitudinally. Then individuals with the chronic insomnia have a high risk of depression and suicide, after their medical college or during the medical college. So it is, in a way, a chicken and egg situation, but definitely presence of chronic insomnia increases the risk of developing depression and mood disorders, bipolar disorder, PTSD. They are intertwined. In sleep problems, you cannot address the bigger issue of mental health without having a deeper understanding of the sleep issues and all that. And I think it's so ironic that still we have not really integrated, even in the United States at the community level, the academic center and the research is way over there, but the practices of chronic insomnia, we have not really started looking that every mental health, every psychiatric disorder must have a hygienist along with that one. If you don't focus on that one, thinking, oh yeah, let me just treat with the depression, antidepressant medication, and insomnia will go away. That's not true. I think, and then if you don't focus on insomnia, then it is even more difficult to treat depression. Bipolar is the other example. And the reason why we don't do that, because it really takes some time to know the patient, because there's so many things are going on, and that why people end up in having insomnia. Their adopted behavior, maladopted behavior, sleep hygiene, smoking, other things and all that. So you really have to spend time to dissect what are the reasons that why this person having insomnia. The very medication which you are taking for depression, for example, they can also be part of the problem. Some of those medications which you are taking for depression, they can cause other sleep issues such as restless leg, which is like uncomfortable leg, and then you move your leg throughout the night. They can cause insomnia. And then so that's, I think it's such a complex, but the point which I'm trying to make over there is that in every depression, anxiety, bipolar, the mental health, basically, the sleep should be integrated like this. Not like you just said with the sleep specialist, psychiatrist over here.
They should be integrated.
Integrated, because what works for the sleep also basically good for depression. It's good for bipolar, such as exercise programs, sleep hygiene, and all that. So
absolutely.
They each other both, for the health and the disease.
Okay, so what are some cures for people? So getting to the underlying cause of this insomnia would be like a cure. I mean, do you recommend taking a melatonin or taking some sort of natural sleep aid, or like, what's your opinion on that?
So I think so. So now we move on to, we call there's a very nice model. If we just remember that model, how we get to chronic insomnia, and I think we will have a better answer, and I will give you the answer indirectly. It's called the 3P model. 3P for Pat. 3P model. This was in 1987. Dr. Spillman has a model. It's called the predisposing factors, which are psychological, physiological. There's very little you can do for those factors. You are genetically very vulnerable. You are very hypersensitive and all that. So they are predisposing factors. But still, there are a lot of things that we can do to change the personality and then change those sort of characteristics. And then, now let's say that you are predisposed. You are very sensitive. You are, every little thing basically causes a lot of ripple effect emotionally and all that.
Yeah.
Now you end up in getting all of a sudden a big stress of your life, such as marriage, divorce, and stuff like that. Now you were able to handle your sleep, not as great, because you have predisposing lighter sleep and all that. Now you end up in having some lifetime event, right? Precipitating. Now that precipitating event have such a big ripple effect on you that you end up in having a chronic disturbances of the sleep. Now you start getting the chronic problem in the sleep, then you maladopt certain things in order to counterproductive behavior, such as that you, for example, sleeping inappropriately in the daytime because you didn't have a good night's sleep at the nighttime and you are taking the nap inappropriate time. So I think, and staying in the bed longer because you're so tired, those very habits are counterproductive for insomnia. The second problem is that the chronic insomnia, rather than looking forward to go to the bedroom, wow, I'm going to relax, this is my time out, you start getting jittery that I'm not going to get sleep. It will be another restless night. You go there, you turn the light, your mind is racing, you are looking at the clock, you're tossing and turning, and then you become like fearful of basically falling asleep, and then your whole cognition, your entire thinking about the sleep changes. So we have to look at that one, how the same bedroom, which was meant for sleep, and I think you're with the spouse and all that, it becomes like a factor which is basically causing you jitteriness. So we have to, so coming back now, where do we fit into the treatment? First of all, understand that what are the underlying contributing causes for insomnia, psychological factor, circadian rhythm problem, people who are sleeping very late, waking up late. They say, oh, well, I cannot sleep till 2 o'clock. And then you diagnose insomnia. In fact, you basically have to say, well, you are sleeping late, but you also can sleep till 10 o'clock. So it's not per se insomnia. It's just a biological clock. You end up in going to California or coming over here. So you have to address those issues. You have to look at the medical causes. So after looking at all those things, I'll say, okay, we got it. So treatment-wise, I will look at your sleep habits. I will look at looking at the clock habits. I look at what are your thinking about the sleep is. Are you really afraid? Are you really very nervous? If I don't sleep, my day is ruined. Heaven's sake, I need some help and all that. So you have to sort of take the fear out of the picture. So the most effective treatment for chronic insomnia, it turned out to be not the medication. No medication has shown long-term improvement with insomnia. All these MBN, billions of dollars basically have been spent. They are short-term as a bridging gap. So what is the treatment? You ask the chronic insomnia. It's called the cognitive behavior therapy. I have to talk to you. I have to basically have a psychological evaluation that what are the essentially attitude towards sleep, what are your habits are, what are you thinking about the sleep, and then the sleep hygiene. Sleep hygiene means you are no exercise, you are smoking in the evening, you're drinking, for example, just to calm you down, to relax. If people go to alcohol, it can make you to sleep, but again, alcohol is not a treatment for insomnia. And so you have to sort of be very, very careful. The small band-aid basically always have a side effect. So you have to work your way up. Cognitive behavior therapy, I'll tell you not to look at the clock. I will essentially tell you, okay, rather than dealing with your anxieties and worries in the bedroom, why don't you basically take your time at 4 o'clock, 5 o'clock, write down the thing which you will be thinking in the bedroom. What is your main 3 problems? How are you going to solve it? Then I will advise you to take a little bit of a walk, a little bit of exercise, calm yourself down, take deep breathing exercise, and then start thinking about that I'm going to the bedroom, I'm going to read something, I'm going to watch something and all that. So then you are not looking at the clock, you are not thinking about the sleep, but it all combination of these things, I think, fall into 2 categories we call the cognitive behavior therapy and the sleep hygiene. And so those are the main treatment, CBT and the sleep hygiene, are the key part for the chronic insomnia. There are medications. I think we have made a lot of progress, I think, over the period of time. They initially were the so-called the benzodiazepine and the benzodiazepine type receptors, MBN, Lunesta. Those medications are effective, but they are short-term. They're long-term, insomnia. They don't last that long. And then now the new medication, which I think work through the certain neurotransmitter in the brain, I think, which addresses the issue of your hyperarousability. So they addresses the specific, they're very targeted solution for the medication, which have a less side effect or minimum side effect as compared to the benzodiazepine. They are becoming also part of the treatment, but for 3 months, for 6 months, but no medication has shown that you take that pill and you take it for the next 20 years, not going to work. Ultimately, the cognitive behavior therapy will give you the tools to counteract your
I love
your
that.
behavior. And since there's some problems are constitutional, they will not work, but certain other things which can aggravate, we can improve them. So CBT, the answer is cognitive behavior therapy.
And I feel like that could be good, not only just for sleep, but other things in your life. Some people have, certain things that are blocking them from success or really the life they want or intimacy or love or whatever it is. So I think CBT, cognitive behavioral therapy, can be so beneficial
Yes.
for not just sleep, but everything really. But if you're not sleeping well, so we're running out of time, but I do want you to quickly just go over what sets up a healthy night of sleep. Is it no blue lights, no phones, what is it?
Well, I think that there's some basic principles you can write down, and you can really right now. I think you don't have to see a doctor. Go to ChatGPT and put down sleep hygiene. Sleep hygiene. I think it will tell you that the 4 or 5, 6 principle of sleep hygiene, which essentially include some exercise program, which include, I think, not to having a stimulant, smoking, coffee, exercise program. So there are 5, 6 principles which include the sleep hygiene. That's a good starting point. Don't take the nap, late in the evening, because if you take a nap late in the evening, it's going to affect your natural sleep. Keep your routine state. I think you go to the bed when you're sleepy and tired, but wake up at the same time. I think that creates some discipline. What happened when you sleep late, you wake up late, and then you wake up late, then next night, again, you start back again. Weekend comes, you say, oh, let me just sleep over till 10 o'clock, 11 o'clock. Okay,
right.
Well, then the Monday, you have to wake up in the morning and you solve the whole cycle again. So I think regularity in the sleep-wake cycle is very, very important. I usually suggest that the habit of looking at your WhatsApp in the very end is not a good idea to do that. I think make your environment basically comfortable, less noise. So all these little things, sleep hygiene, just like a body hygiene,
Like I have to sleep. I'm in New York City, so I have to sleep because I think I'm hypersensitive. I have to sleep with like a white noise machine or I can't sleep.
That's okay. I think that because your environment.
I love it.
Yeah, the part of this thing is the sleep hygiene. I think we can include into sleep hygiene the environmental noise. Basically, that we have sleep is very sensitive, particularly if you are a sensitive person. You happen to be, and now you're sleeping in New York City.
I am, yeah.
Wish you the best of luck. But yes, I think those things are very, very important. So all these, I think, simple common sense things come in the sleep hygiene, and you have done that.
Yeah.
You are exercising, you are essentially avoiding the caffeine, coffee late in the night, not smoking at the time, avoiding the light therapy from all these gadgets and all that. Mentally and psychologically, you're not engaged at 2 o'clock.
Like read a book, not a TikTok video.
Read a book. Faith does help, prayer does help, and all the way you can absorb
that. Yeah.
into that thing, either it can be music or the prayer and all that, where psychologically
I love that.
Absorb in that one rather than thinking about the sleep, rather than looking at the clock, getting more upset, more you're looking at the clock. Oh my God, it's 1 o'clock. Oh my God.
I didn't think about that. Yeah, that's such a good thing. Oh my gosh. Okay, so where can people find more information, contact you, get in touch with you, work with you, all that good stuff?
Well, I think they should start with the ChatGPT. I think
we got that part. Where do they find you?
Okay. They will find me. I think that I'm right now working in Pakistan. I think there's virtually the entire. I've visited many places, lectured, and there's not a single program which I can't do the justification for the chronic insomnia. CBT program, cognitive behavior. Even psychologists are trained in CBT for depression and anxiety, but CBTI is called the CBTI, CBT for insomnia. They are not trained in that one. So I'm doing my work in Pakistan, and I hope that I think with that one, to me to find out my my email or my LinkedIn, I think I can.
Do you have a website?
I basically. Yes, I do have a website, but again, it's a program which is doing in Pakistan. I think it will be difficult to get hold, but I can send you some information where they can get. But again, there are fantastic resources available. I think there are big leaders in the sleep area, insomnia, the CPAP, started in the United States.
All right, but you're on LinkedIn though, right? So they can reach out to you if they have questions.
The CBT program is available online, by the way. CBT program, you do the CBT, they are online available. You don't have to go see a psychologist and all that. There are a lot of online.
That's great to know.
CBT program online are available. And the few good names, which I have a lot of respect, Anne Germain. She is one of the best known person, I think, in the PTSD and the CBT.
What's her name?
Dr. Anne Germain. She is from Montreal.
How do I spell that?
Anne, A-N-N, Germain, Germain, Anne Germain.
I love it. Okay, perfect.
She is, I think, my hero. I think that she is an amazing person. And she's working on this thing with the chronic insomnia. There are many other, but I happen to know her because, being a Canadian and have a lot of respect for what she's doing, and particularly with the PTSD, because PTSD has been a big thing with the military and the people who come back. You cannot deal with the PTSD without understanding of the link between the sleep insomnia and PTSD.
Oh, I'm sure. Yeah. Absolutely. So, and then you're on LinkedIn too, if people want to connect with you.
Yeah.
Okay, so you guys go definitely check him out on LinkedIn. It's Dr. Mansoor Ahmed. How you spell his name is in the note chat, so definitely check that out. And just remember, what's that?
I will text you my LinkedIn.
Okay, perfect. So we'll put it in the show notes. But yes, you guys, sleep is absolutely critical. So fix your sleep, fix your habits, fix your lifestyle. I love the cognitive therapy thing that you put down. But yes, if we're not getting enough sleep, we don't feel ourselves. We don't have the energy to live healthy lifestyles. We don't have the energy to go after our dreams. So fix your sleep, fix your life. But I always say fix your sleep, fix your thoughts, and sleep your life. So I like how you put in the thought process, because your mind and your thoughts create your reality. So you really tied that in, where it was like, if you think, oh God, I'm not going to sleep tonight. Oh God, I'm not going to get to bed. That's what you're creating, because your thoughts create your reality. So I love that you wrap that right back into a package like a bow.
There's so many heartwarming stories which you didn't get to that one. I think Ariana Huffington is another Ariana Huffington post. You know Ariana Huffington. She used to be author of
the
She's book on insomnia. She herself basically have battled with this thing, and she is a big champion of chronic insomnia. So write down that name, and I think that the book is worth reading over there, Ariana Huffington. And there are stories, patients with PTSD that who lived with PTSD since the Vietnam days. A veteran came to see me, I think, years back. Sleep apnea, he has it. We got it under control. Then he came back again. Dr. Ahmed, I'm still waking up. I'm not sleeping very well. And so I said, that, tell me about you, who you are. I think after sleep apnea was controlled. He said that he to Vietnam. I said, oh my God. I said, tell me about how the Vietnam, you basically talk about the sleep. And then he told me that he was having the nightmares. And then we talked more. Then he eventually basically was classical patient of the PT. I said, why didn't you tell that you have these nightmares? I said, nobody asked.
Oh,
I think that is the other major.
Well, we gotta have you back on, because we're running out of time. But we gotta have you back on to talk about just the link between sleep and PTSD. So we will do that absolutely in the future. So you guys, thank you so much for being here and educating us about sleep and giving us some healthy habits so we can all have better sleep. And thank you to everyone who is listening, wherever you may be. Don't forget to subscribe, rate, review, share with your friends, all that stuff. Almost everyone you know has some sort of sleep disorder. So please share this episode, because this podcast is designed to make you happier, healthier, and wealthier. And we do that by sharing and putting out good energy into the world. So we will see you next time to find out who's next. Bye.
Thank you.
Hey, your host here, Madison Malloy. Please make sure to subscribe to the show on all podcast platforms, and please rate and review us on iTunes and Spotify. Also, if you have any questions or comments, you can email us at contact@nexttomadison.com. I thank you again for listening. Bye.